Our last speaker for this section is Dr. Hollingshaus. Did I say it right? Reasonably close. So we'll turn the time over to Dr. Hollingshaus.
Thank you very much. Good morning, everybody. Honored to be here. I'm grateful to be able to talk to you today. I'm a sleep medicine specialist. I'm an assistant professor at the University of Utah, but I spend most of my time at the VA, where I'm the chief of sleep medicine and currently acting chief of medicine there. For the next, I guess I got to use this thing, just the forward button. Push this one. Nope. Oh, the big green arrow. Okay. I don't have any financial disclosures to reveal. Over the next 24 minutes or so, I hope to kind of discuss some of the things that have been happening in sleep medicine, particularly related to one of the largest recalls in the medical field, the Philips Respironics CPAP recall, exploring how COVID and the recall created a situation of scarcity leading to kind of adoption or more rapid adoption of modern sleep medicine delivery models, reviewing some of the alternatives to PAP therapy, such as some of the newer hypoglossal nerve stimulation, transvenous phrenic nerve stimulation therapies, and then a little bit on learning how to interpret CPAP machine download data, because it's one of the things that my primary care colleagues have wanted to know most commonly from me. And by the end of this, hopefully you'll be able to answer some questions. So as far as the recalls go, and yes, there have been 5 of them now since 2021. And these are all related to Philips Respironics, which is a CPAP manufacturer and equipment manufacturer. They're machines which have been on the market for many, many years, as well as some of their masks. We won't go into detail on 2 of them because they're pretty isolated. One, the ventilator recall, due to inability of some of these machines to calculate FiO2. These are mainly inpatient ventilators, and they're being replaced. And the other is a BiPAP recall that's kind of been bundled into the main recall related to plastics. But the main issue with the mask recall was revealed on the 14th of June in 2021, though our representative kind of told us in April what was happening and kind of the writing on the wall. He isn't the rep anymore, but I think he kind of saw what was going to happen. But there's a foam in the machine that's used to reduce sound. It's sitting in the air channel. Sound and vibration is the goal, to reduce that for the patient's comfort. And there were reports that this foam was susceptible to degradation and off-gassing of certain volatile organic compounds, with 2 possible event hazards. First, this polyethylene, polyurethane foam may degrade into particles which may enter the device's air pathway and be ingested or inhaled by the patient. And then, it may also off-gas certain chemicals. Either event could cause health problems for the consumer, including upper airway irritation. There were about 5.3 million devices recalled. I think, and this is what some of my colleagues at the manufacturer have stated, is one of the main concerns that they had is that there's a carcinogen risk. This hasn't been proven, and in fact, a study done later that year, or published later that year, retrospectively looking at all the different manufacturers, indeed did not see an increased risk in the incidence of cancer in patients who used the recalled device versus other manufacturer devices. But in the internal testing that was done by the manufacturer, they did identify as an off-gassed volatile organic compound as dimethylene diazide, which is another word for azomethane. And azomethane can be oxidized into azazomethane, which is I wrote that wrong, but azomethane and azazomethane are different, but which is a potent inducer of colon cancer. And so the concern was that if these machines had the foam degrading and that foam was getting into the air channel and was exposed to other oxidizing agents such as third-party sanitation devices which use ozone or ultraviolet light, these could produce carcinogens that patients would be inhaling. So that occurred in June. And very quickly, the AASM, which is American Academy of Sleep Medicine, kind of recommended everybody should just replace their machine with a different machine. You can't really do that because manufacturers don't decide, hey, I'm going to produce double the equipment this year because I think my competitor's going to have a massive recall, and I'm going to be able to sell all these devices. So what happened is a lot of patients did do that, and this was in the throes of COVID. Their competitor just simply did not have the capacity to produce enough machines to satisfy this demand. And actually, within a few months, the number of the machines were pretty much reduced to zero. Fortunately, Utah is an area where most of the DME companies around here use the competitor's device, and so we weren't affected as greatly as some other areas, but areas in the East Coast or on the West Coast where they were very heavily invested in the recalled equipment, you couldn't get a CPAP machine to treat your sleep apnea for months. And in the VA, actually, we had to implement a national kind of allocation of scarce resources model saying, based on clinical factors, who can get PAP therapy for their sleep apnea, which, as you can imagine, causes a huge problem because 15 to 20% of of our patient population has sleep apnea and would benefit from treatment. So this led to us moving and marshaling other resources, and we'll kind of get into how that's affected sleep medicine care in a minute. The other recall, and I'm bringing this one up because it may not have been as big or noticed as heavily in the media, but this is related to masks. And there are certain masks, the masks aren't faulty, and it wasn't a, so what happened is Philips was deciding to push a new mask that uses magnetic clasps through FDA clearance. And they had been looking at their aftermarket research and had seen that many patients were using these masks because magnets is typically rated as the highest feature that people like in their PAP mask because it makes it very easy to put it on and take it off. But they were using them in risky ways. So there's a warning in the label that says if you have a medical device that you shouldn't be using these. It wasn't listed as technically a contraindication, though it did say you needed to make sure that you didn't put magnets close to your pacemaker or try to hang them from your implanted piece of metal as a party trick or something. But people were doing that. And so they decided to change the labeling and add a whole bunch of contraindications. And whenever you increase the level of risk for an indication in FDA, that gets called a recall. So these devices weren't taken off the market. They were just kind of, there was an embargo basically to their distribution while they changed the labeling and remediated, got these other patients put on different types of masks. The reason I bring this up is because there are other manufacturers that use magnets in their masks. They kind of hinted that, the reason that Philips is doing a recall is because their magnets are stronger than ours, and ours are all underneath the 400 millitesla level that's set by the International Radiology or whatever. I can't think of the name of that acronym, but it turns out that Philips masks actually were probably had the weakest magnets of all of them in testing that was done. And that 400 millitesla mark was set as, this is the level under which a magnet will not interact with biological material, meaning it won't interfere with blood flow or things like that. But magnets that are weaker than that can certainly interfere with other electromagnetic fields and can attach to ferromagnetic materials. So I expect that down the road you'll see a lot of other companies' masks when being recalled as well, as they have to adopt and change their labeling. These are the masks that were in question. The one on the end is called the therapy mask 3100. That was the one they were trying to push through clearance and then issued the recall on these others. So if you do have patients who use these masks, there are new contraindications where they shouldn't be within a foot of medical devices, which means if they have a pacemaker or other medical device, or their bed partner has a pacemaker or other medical device, they really shouldn't be using these at all. What they should be doing is contacting their equipment company, and the manufacturer has set up kind of a cross, they call it a crosswalk, where if this is the mask you're using, you can switch to this one that's very similar but doesn't have magnets. The new labeling you can see is very cumbersome, but it has been adjusted, and these it's been added to the new packaging, and these masks are back in circulation. But you should be aware that if your patient has a pacemaker or something and they use CPAP, you should probably make sure that they're not using a mask that has magnets, as it may put the pacemaker into the default mode or interfere with it in other ways. Seem to be talking ahead of my slides. That's okay. All right, so as far as sleep medicine delivery goes, telemedicine has kind of become the norm during COVID. Of course, as of this week, that's kind of changed, and now we have to kind of figure out how we're going to navigate this landscape. Fortunately, there have been some extensions made to the use of telemedicine. Fortunately for me, working in the VA system, we kind of have differing rules in how we have to deal with that kind of stuff. But in general, sleep care is impossible to do the way that we used to do it. You can see here in the panel on the left that the demand for sleep care, and this is just looking internally to the VA, has skyrocketed. And that doesn't mean that more people have sleep disorders, probably more recognition. Once you have a treatment available, now all of a sudden everybody has the disease, right? Until you can treat it, nobody gets diagnosed, because I can diagnose you with something I can't treat. I don't know if that's hubris or what, but that seems to be the way that history works. Now we have all these different treatments. Things are being realized. We're getting tons of patients. And sleep medicine, we have about one physician for every 43,000 people out there, which is not nearly at the level that we should be. You look at other specialties, and even some of the more rare specialties, and you're going to see much higher ratios of patient to, or lower ratios of patient to physician. So we had to kind of change our models a little bit. This is a heat map of distribution of physicians for sleep medicine. Utah's kind of in the bottom with most of the Midwest and Mountain West. The VA and the Department of Defense have set up kind of different treatment guidelines, trying to curtail the influx of demand into the system. The American Academy of Sleep Medicine has proposed similar systems with kind of a primary care centric, I guess the sleep's at the center of the wheel, but a hub and spoke type model where primary care is doing more of the management. An accredited sleep center is involved in testing and more complicated cases. A lot of issues come about in terms of compensation and how in the world are you going to be able to do that. So you won't actually see a lot of this just yet, but this is kind of the way that things are moving. But there are some benefits to distributing care and using telemedicine. Particularly, you can streamline the diagnosis and treatment of sleep apnea. You can enhance the patient experience and reduce wait times, which is one of the big issues that we deal with. Sleep is benefited by the fact that very, very rarely does physical exam actually affect the care, so we can really do almost everything virtually as long as there's a mechanism for us to be compensated to be able to do that. You can't do it for free. So let's move then into how this has affected sleep apnea treatment. You have the diagnosis of sleep apnea. It's either mild, moderate, or severe, and then you have different kind of traditional therapies: upper airway surgery or airway stimulation, positional therapies. MAD stands for mandibular advancement device. It's a dental appliance, or CPAP. Traditionally, CPAP has been really the only treatment for severe obstructive sleep apnea until Inspire and these other upper airway stimulators have kind of come online. Dental devices had been reserved for mild to moderate sleep apnea, though newer research is showing there are ways where we can actually get success with these other therapies. So these are what kind of different treatments look like. Dental devices, CPAP, or airway stimulation. Auto-titrating CPAP is going to be the mainstay of treatment still. Auto-titrating CPAP uses mathematical algorithms and analysis of the airflow and pressures through the air channel and makes determinations on whether or not the pressure is adequately maintaining the airway. So it looks at kind of the shape of the inspiratory curve, it looks at the tidal volumes, it either increases or decreases airway pressure appropriately, or what it believes to be appropriately as programmed by the engineer. Patients who are good candidates for this treatment are people with moderate to severe uncomplicated sleep apnea. People who have positional sleep apnea where, depending on their position, the pressure needs are different substantially. Patients who had bariatric surgery recently and are planned to have significant weight loss, and therefore their pressure needs are going to be changing over time. Pregnant women who are in a similar physiologic state as bariatric surgery in a sense, I guess. Or people who experience certain side effects related to pressure, such as aerophagia, which is air eating or air swallowing, which leads to bloating in the morning. People who are bad candidates are people whose breathing doesn't look normal at baseline. And if your breathing doesn't look normal at baseline, the mathematical algorithms of these machines fail. They can't make determinations. They can't say, this looks different than that, because everything looks weird. So people with pulmonary disease, congestive heart failure, people with hypoventilation syndromes, or people with central sleep apnea, where the treatment's different anyway. So when you see a machine download, it presents pretty useful information. It gives you statistics on adherence. It gives you, on an auto-titrating machine, pressure distribution statistics for the patient. It gives you a machine-estimated residual sleep apnea index. And it gives you some other statistics, particularly related to leak. Its algorithms are reasonably good at detecting apneas. They struggle to differentiate between the two types of apneas, central and obstructive, so I don't put a lot of weight in the distinction that the machine gives. They're really poor at detecting hypopneas. The R-squared value on the test was about 0.6. So, and the reasons for this are pretty clear in that we're not measuring the same data, so we can't come to the same conclusions. In a sleep lab, we're measuring physiologic properties. The machine is only measuring airflow through the tube and isn't making inferences about the patient. So when you give cutoffs, because you have to have some sort of cutoff of what constitutes an event versus not an event, you have to make distinctions, and those definitions are different. And if the definitions are different, then they can maybe correlate, but they can never be accurate. And the precision can't be high. So one thing I see a lot of is if the patient is complaining that it's not working, they're still tired, and the machine says everything's fine, you should trust the patient and not the machine. And in those situations, you should get physiologic data, either through overnight oximetry, or a lot of centers now can do home sleep apnea testing while using PAP therapy. The gold standard would be sending them into the sleep lab for a titration study, though that's very expensive and often not going to be covered by insurance. But something needs to be changed. The other important fact about this is if there's a lot of leak, then the numbers are meaningless. The signal-to-noise ratio is unfavorable, and the machine's data is compromised. And so if the leak is high, and for most machines, the magic number is 25 or 24. If the leak number you see is above that, then you can just ignore everything else the machine says. It's not worth your time looking at it because you're not going to be able to make sense of it. And the other thing I see, the last thing I see with these is if a patient is morbidly obese, once their BMI hits 35, and I don't trust the machine data because I know it's underestimating their hypopneas. The machine may say they have an AHI of 1 per hour, and I do an oximetry or I do a study on them, and it's like 40. And it's just because of the way these machines are set up. So I guess the point there is, don't trust the technology at this point. It's useful, but it has its limitations, and do not apply it outside of its limitations. So looking at dental appliances, traditionally these had inconsistent efficacy. However, talking about what's new, there are these self-adjusting mandibular positioners that are kind of new that can be used in a sleep lab or via home sleep apnea testing. And these can improve the success of mandibular advancement in mild, moderate, and severe sleep apnea substantially. Basically, it's doing a titration with the device, but it uses a servo to move it, so you don't have to wake the patient up and adjust it and then put them back to bed, because that's really cumbersome and makes titration difficult, and doing it at home would take forever. But you can get these positional advancers that kind of make these adjustments. With the use of these and with some other more precision techniques for creating dental devices, there are applications to the FDA to kind of create a new classification of dental device for precision appliances that would hopefully be indicated for moderate or severe sleep apnea and can have success rates up to the level of the hypoglossal nerve stimulators and the 60 to 70% success rate. So hypoglossal nerve stimulation, this is, everybody hears about it. It's on the news, it's on TV. It's borderline unethical marketing. But this is for patients who have failed, meaning they still have moderate sleep apnea on PAP or intolerant of PAP. They have to have moderate to severe sleep apnea, but it can't be over 65. And this needs to be done using the Medicare definition of what a hypopnea is. Their BMI has to be low. 32 is what's indicated in the FDA. They suggest not using it over 32. Some centers are pushing up higher. Medicare will cover up to 35. And it needs to be pretty obstructive. They shouldn't use it if they have paralysis of the hypoglossal nerve. The question I ask when a patient comes to me is, I say, if this patient were to get this and it didn't work, what would they do? And if the answer is anything other than they would do nothing, then we should just do that other thing and see if that works better, particularly PAP therapy. Transphrenic nerve stimulation, or transvenous phrenic nerve stimulation, is a treatment to treat central sleep apnea. It is indicated for moderate to severe central sleep apnea. It can be used in conjunction with other treatments for obstructive sleep apnea. I don't use this often because there's kind of a philosophical question of, do I care if they have central sleep apnea or not? Is it going to cause a problem? If they have symptoms, then I would address it. Otherwise, probably not. Weight loss does improve sleep apnea, and with all the other drugs that are available now for weight loss, you could expect improvement in sleep apnea. They haven't been tested for sleep apnea, so these ones have been tested, but you can make inferences based on that. Other sleep therapies, do I only have 30 seconds? Or is that wrong? Okay. Let's move on to digital therapies. I don't have a lot more here, but so digital therapies are kind of this new thing where you prescribe a digital treatment. This particular one is called nightwear. I would caution you of Googling the term nightwear. But if you do, make sure you qualify it with some other buzzwords that will get you in the right direction. But this is a treatment for PTSD-related nightmares. It is FDA approved therapy. It provides this vibrotactile biofeedback via an Apple Watch that's been hacked, so to speak, to awaken the patient from a nightmare. It uses the haptics, but I think they supercharge them because my haptics never wake me up. They just make me think that people are tapping in my dream or something. It shouldn't be used alone. It should always be used with psychotherapy or with medications for PTSD. It is contraindicated if the patient has dream enactment or other parasomnias. The reason for this is if you awaken them, you could induce the parasomnia or the dream enactment. And the other problem with it is its coverage is limited. In the VA, we have kind of a debate between the sleep professionals and the psychiatry professionals who do the psychotherapy, and we feel like this is a good treatment. They're not quite on board yet, but we'll kind of see where that goes. Then we'll finish up here. So, what's coming in the works? The hypoglossal nerve stimulator therapy is pretty cool. I mean, Utah probably does more than a lot of other states because we have a lot of ENT surgeons who can actually do this. They have applied to the FDA to increase the labeling in the BMI from 32 to 40. The reason it was left as 32 initially was because the pivotal trials that showed efficacy really only included patients who had a BMI less than 32. And the aftermarket studies that they were doing at the time clearly showed that there's an inverse correlation between BMI and success. And so as BMI goes up, it's less likely that it's going to be effective. But if the new data they're submitting to the FDA shows that this therapy is beneficial in patients with a BMI up to 40, then that opens the availability of this treatment substantially. It may not adjust the evidence in terms of, insurance companies covering it. They usually look at cost versus benefit analyses, and the current cost-benefit analysis using the pivotal trial data was just barely beneficial. So if you start raising the BMI indication and success goes down, you may no longer have a beneficial analysis there. There are other new digital technologies addressing panic, PTSD, PAP tolerance. This one isn't approved, but there are trials going on looking at using a treatment that is approved to treat PTSD called Freespira, using it to improve adherence to wearing a mask for PAP therapy. And then, as I mentioned earlier, these other applications to the FDA for indications for dental devices. I didn't discuss today drugs, particularly drugs for hypersomnia, insomnia, narcolepsy, things like that. And the reason is why they can be successful, in my opinion, if you're to the point where you need to consider one of those, then you probably should reconsider your diagnosis and send that patient to a specialist to see if they really actually have the disease you think you're treating. In conclusion, sleep medicine is changing. It's relatively new. PSG started in the 60s, and sleep medicine really didn't take off. Well, I don't know if it's taken off, but until the 1980s, it wasn't really considered its own specialty at all. Be cautious of PAP data download. They're not all that they claim. And while PAP therapy is still the gold standard, these other treatments are being rather disruptive to the field and are having some promising results. So I expect more change to be coming. Thank you.
So we do have time for questions. I have one first, since I'm at the microphone. So a lot of people now are wearing Apple Watches and other wearable devices. And one of the newest questions I've had is, my Apple Watch shows that I don't sleep well. Is that a legitimate bit of data or not?
I think the data are the data. So if your Apple Watch says you're not sleeping well, that's what your Apple Watch says. Does that mean you're not sleeping well? I will say, and all of these things are labeled as, not to be used as medical devices for entertainment purposes. The algorithms used in those focus mainly on motion. And I will say that if your watch says that you're awake, you were probably awake. And if it says you're asleep, you were maybe asleep. But with Apple Watch particularly, and some of these others, you need to make sure that it's tuned correctly. There are different settings on the sensitivity of the machine and how it differentiates wake to sleep. Fitbit, for example, has a sensitive mode, which is the default mode, and then the standard mode, which is the not default mode. And for me personally, if I adjust that, I seem to get better numbers, or at least more in line with the way I feel. But as far the AASM does have out there information regarding their stance kind of on wearable consumable technologies for sleep monitoring, and at this point it's like the main benefit is that it helps people get engaged and ask questions, right? That patient wouldn't have brought up their sleep problems otherwise, and they probably do have sleep problems, and so it's useful in that way. But I wouldn't put a lot of stock and be like, oh, we need to make that number better somehow. Or worse. I don't know what better or worse.
Okay.
Maybe you covered this, but where would I go to send somebody for one of these self-adjusting mandibular positioner devices? Is this something I refer to a sleep specialist? Is this something I refer to a dentist? Well, where do they go for this?
So this is relatively new technology, and most sleep studies, I know at the University of Utah, we're able to do titration of mandibular devices. There are a few dentists in the community that all they do is sleep medicine dentistry. They have pretty good relationships with some of the labs, and the labs will do titrations. I don't know of any that have actually implemented yet the actual self-adjusting servos, but even doing a non-self-adjusting servo titration is probably better than just the set it and forget it technique that a lot of our dental colleagues use.
Okay. Thank you very much.
Thank you.